this week's episode. We really appreciate you joining us. This podcast really shows us how we can all learn, live, and thrive off of each other. By sharing our knowledge through our conversations, we will impart some knowledge whilst learning ourselves how to progress even further. Here is your host.
Hello and welcome to Mind Hostage Podcast. I'm your host, Stephen Payne. Today we have a special guest, Dr. Christopher Colvin, who is an accomplished emergency room physician, emergency medical service medical director, and author. And he's going to talk about the coronavirus and what we should be concerned about, what we should not be concerned about, and just some general infection control guidelines that can help us in avoiding contracting the virus. Dr. Colvin, thank you for coming on the show today. Would you please share a little bit about yourself?
I'm a emergency medicine physician here in Central Texas, and I've been practicing medicine for quite some time. I graduated from medical school in 2003 down in Houston, and got to learn from people like Dr. Cooley and Dr. Red Duke and some just amazing physicians and surgeons. I then did my residency in Central Texas, and I stayed on there as a staff physician with a research focus in sepsis for many years, and then eventually left academia for private practice in a community hospital. In the midst of all that, 9/11 happened when I was a third-year medical student in Houston. And I immediately volunteered and got commissioned as a captain in the United States Army Medical Department my intern year, October 4, 2003. Still look back on that day fondly. And I was in the Army Reserves for 9 years. I've seen a lot in a lot of different environments, and I was involved in the 2009 Fort Hood shooting, which left a huge impact on me for a lot of different reasons. And I'm just a kind of a regular guy. I grew up in the country, a cattle ranching family. Grew up outside San Antonio. I love the outdoors. A lot of the things that I enjoy doing is just getting outside and hiking and exploring. I just have a profound love for the wilderness. But I have a family here and extended family in Central Texas, and we're just kind of anchored here for the foreseeable future.
Awesome. Thank you. I wanted to bring you on the show because I've seen a lot going on in the media. It seems to be quite the frenzy about this coronavirus or the COVID-19 virus. And I wanted to bring you on because of your background and talk about the virus and how, what your take is on it and what you're seeing in the emergency room and what kind of things we need to be concerned about. So can you tell us a little bit about what you're seeing?
Yeah, right now we're okay. I think what I would like to emphasize right off the bat is that everyone needs to remain cautiously optimistic. I think that anytime we have a new disease entity, it can be scary, especially when researchers and government officials are trying to continuously evolve their understanding of the illness. But it's nothing to be afraid of. That's just science and medicine in a nutshell. And we have some of the smartest people in the world that are all over this, and they're actively trying to design a vaccine right now. And I think that's something to remember, that the scientific and medical community, regardless of what you may be seeing in the news, we are prepared. We are actively planning daily. In fact, we've been running drills at our facility and many other facilities in the state of Texas now for a couple of months. Since it started coming out of China in December that there was an issue. We did the same thing with H1N1 in 2018. We did the same thing with the swine flu. We did the same thing with the Ebola virus, and we were definitely on top of it. I think the thing to keep in mind and what is important to remember, because people are throwing all kinds of random numbers out there right now, statistics and mortality is what we're really talking about. What's the likelihood that this is a deadly thing that I'm going to suffer or die from? And we all tend to think of of ourselves or who's in our home first, and how that's going to impact the people we care about. And the reality is, mortality rates over time are likely going to go down, not because we've done anything different in medicine, but because of statistics. And in a basic fraction, right now, they're only testing people that they know have the disease. So you've already kind of got a biased, a positive high mortality rate there. But when you start testing all the people with mild disease, low-grade fever, a little bit of muscle aches, and a runny nose, and you see that they don't die, then you start getting a more true defined mortality rate. And most of us in the medical community believe that once we start testing everybody, you'll see that the denominator is going to get really big, and that you're going to see the mild end of the spectrum of illness, and your mortality rates will go down. What we will probably see over the next few weeks is that as testing becomes more available throughout the communities in the country, you're going to see an increase in the number of coronavirus cases, but it's mostly because now we're looking for it and we're finding it, and that's just something to be mindful of. So far as what to do for yourself and for family and friends, don't let the fear paralyze you. I think it is important to cancel non-essential travel. You don't have to buy all the toilet paper at Walmart. That's not necessary. That's been going on a lot. It is not a GI virus. It's a lung virus. But I think understanding the importance of basic hygiene, and understanding that if someone's coughing, teaching your kids and people in your household coughing to your elbow, they have walked back, the CDC and the World Health Organization have walked back their recommendations. They originally had air isolation protocols and whatnot, but now they're looking at droplet precautions, and that's a different level of intensity so far as of control. And so it's looking more like you have to be within a close proximity of the person, that it is in the cough and the sputum and the nasal drainage and tears, and they're finding in the virus in stool and whatnot. And so it's not going to be as aerosolized, as widely dispersed as other diseases that we know exist. So making sure we control our coughing and our droplets and our sputum, and making sure that we wash our hands and that we try to avoid touching our face, which is really just because you don't want to get the virus in a droplet on your fingertips and then you introduce it into your body by rubbing your eyes or your nose or your mouth. And then being mindful of the fact that we are going to reach a point over the next few months where we know this virus hurts the elderly. We know that. When you look at some of the initial deaths in the country, it was in Washington State, and a cluster of them, almost half a dozen or more, were all within the same nursing home in Washington. And all of those patients that died were elderly patients with multiple medical problems, including heart and lung disease. And we know this virus attacks the lungs. And so when we see that, it's being mindful of our resources in the healthcare system in America, and that we need to focus on the sickest people. And if you have a runny nose and a cough and low-grade fever, but you otherwise feel fine and you take Tylenol, Motrin, and you're staying hydrated and you're doing okay, you don't need to go in an ER. You don't need to go to the clinic. You can stay at home and call in sick and just kind of be mindful of the fact that you're probably going to be okay, but you should seek medical attention when you start having a hard time breathing, or when the fevers start to get high and you feel like you can't control them. In America, as you know, from your career, we have a federal law called EMTALA. And so every ER has to see every single person that presents themselves if they consider it to be an emergency. And so a lot of what we're trying to do is avoid this overwhelming flood of people that we call the walking worried well, that will take up resources from people that are actually sick. And it's not fair to ask people to self-diagnose. We're not doing that. But if you have mild symptoms and you're doing okay and you feel like it's a regular cold, it could be the coronavirus. We know that a lot of people that have the coronavirus actually have very mild symptoms and get over it in a week. And so all those things are about just being comfortable with understanding some of the things you can do to avoid it, basic hand hygiene, and knowing when you're sick enough to need to seek medical attention. One of the things that I think is helpful right now that's kind of new in medicine is what we call telemedicine. And there's a lot of services now that are recommending screening exams over the phone. And so you can call or pay a subscription or pay for a visit on your phone. And depending on what service you pick, you can actually get a board certified physician in America who will FaceTime you on your phone They'll go through your symptoms, and that's a little bit safer because now you're in the confines of your home. You are talking to a medical professional, but you're not getting exposed to or exposing other people to your symptoms.
Yeah, very cool. Well, you're talking about that, and I kind of want to reemphasize some of the infection control measures that you talked about. But it sounds like the same is true for just about every other illness that we face, the common flu, the common rhinovirus, rotavirus. Some of these infection control procedures are the same. Yet, one of the things that really it drives me crazy because I go to the gym and I see it. People, the more they run on the treadmill, the more they cough and they don't cover their mouth. And I see people wiping their face and not washing their hands. So, I mean, it seems like the precautions are the same for this as with any other illness. Is that true?
It is. And I think that, what we're still trying to figure out, and again, it's because it's just the data was so slow in coming out of China, is that we're trying to figure out how infectious it is. What's the virulence here? How easy is it to be exposed to the virus and then suddenly come down with the illness? And then, other things that we're still trying to delineate is how long can the virus live outside the body? So if somebody with coronavirus coughs and gets some spit or some sputum on a treadmill at a gym, and they don't think about it and they walk away from it, and then, an hour later you get on that same treadmill and you happen to touch where their spit went, how long does that virus live outside the human body? Some viruses can only live for a matter of minutes, and other viruses can live for hours, sometimes days. Things like hepatitis C, for example, is a virus that can live outside the body for quite some time in body fluids on inanimate objects. And so I think all those things we're trying to rapidly answer. And that's going to be important in the future for how to control it, how to decontaminate a room, for example, and how excessive or how modified the regimen might be if you have something like that in your home. Now, what we do know is that simple things like Lysol do kill the virus. Lysol is one of my favorite things to encourage people to use at home, especially for GI viruses. I always tell people, spray it where you wash your hands on the faucets, the toilet handle, the toilet seat, that kind of stuff, and it kills the coronavirus also. I always have to point out, please don't spray your body. do not apply it to a human being. It's only for inanimate objects, and it's to kill the virus. But there are things we can do to control and mitigate its spread.
So, obviously this is, something that's of concern, but, what are some of the other more common illnesses that we need to probably be as concerned or even more concerned about?
Well, I think the first one that everyone's trying to compare coronavirus to is the flu. And I think it's because it's a known entity. It's something that we're familiar with. We've seen it wax and wane in its severity and its intensity. We have vaccines developed for the flu, and some years the vaccines are successful and some years they are not. There's a lot of debate out there on social media about people not wanting to get the flu vaccine and whatnot. And so I think since that's such a well-known conversation, we have hard data on that now over many, many, many years. We just had a pandemic of influenza 2 years ago in 2018. And I think that's a very important thing to keep in mind because we saw that 100 years prior. And so influenza right now is throughout the community, and we are in the middle of a big spike of influenza. What we've been seeing here throughout Central Texas, we had a huge spike of flu, and it was influenza B, which is, I guess for lack of a better term, the less severe of the two between A and B. And influenza B started to come around October. We started seeing a big spike through November, December, like we tend to do. A lot of national travel, a lot of family holidays. And then influenza B started to die off around mid-January. Influenza A then came in. And so we've kind of seen this bimodal distribution of influenza this year. And so, I just diagnosed half a dozen people last week with influenza A. We have had deaths in Central Texas from influenza A. And oddly enough, and I don't know why, most of the deaths have been middle-aged women in their 40s. All the deaths from influenza have been in patients who did not get vaccinated from influenza. You may still get the flu if you get the flu vaccine, but you're not going to get it to the severity that someone may get if they don't get vaccinated. It's very hard for us to predict who's going to have a bad reaction to influenza. We know that little babies, infants, and we know that the elderly patients and anybody who's immunosuppressed, including pregnant women, that they're going to have a higher grade of severity when it comes to an influenza infection. But it's still hard to predict why a 35-year-old man may die from influenza A and his father, who's 70, did not. And we're still studying that right now. But influenza is everywhere right now, and it is deadly. And we have a protective tool to prevent death, and it's the flu vaccine. And that's really where I'd like to see the national discussions go with coronavirus. Right now, there's so much political frustrations and arguments that everyone's focused on making the test accessible for coronavirus. And it's important to understand, when you're not in medicine, that every test is not a perfect test. Every test in medicine has what we call a sensitivity, which is its ability to detect something wrong, and its specificity, which is its ability to pinpoint exactly what's going on. And you want tests when you're trying to figure out if someone is positive or negative for an infection. You want it to have a high sensitivity. You want the test to be very, very sensitive at picking up the reactants that are necessary for a positive test. And so for the coronavirus right now, we use a PCR test, and not to get all nerdy and go down this rabbit hole of science, but we do have a test that we use that can be found in the secretions of your nose and your throat. We call it nasopharyngeal. You can test it in the blood, and you can test it in the stool. One of the things to keep in mind is that right now, and this is a recent study produced by scientists and physicians in China, at 1,100 patients, the sensitivity of the test is only 70%. What that means is that 30% of the time you can have the disease, and the test will tell you that you don't. And so for doctors, that's not a real helpful test. A lot of people you can see it, it's all over the news right now. People are fighting for access to a test. Yes, testing helps when we're trying to identify patient zero, like where the infection started and who's exposed in the community. But the sensitivity is not real good. So you can still have people running around with mild illness, a little bit of body aches, runny nose, and a cough, and their test is negative, but they have it. And so then they can transmit it to somebody else. And it's something that I would like to see the energy and the focus of discussions across the country, across the world, to be really focused on vaccines. We need to focus on vaccines. Yes, we need a better test. But if you start vaccinating everybody for this, you're going to start saving lives. And right now there are thousands of scientists and physicians and virologists that are really aggressively, actively trying to design a vaccine for this right now. But that's what's important to understand about the test. And so that's why right now we feel like if you have the symptoms, if you have the travel history, if you have remote exposure to people who have the illness and the travel history, that it's just best to assume that you have it. And then we have to take precautions from there.
So would I assume one of the number one precautions being if you feel like you've been exposed or you exhibit any kind of symptoms, to maybe self-isolate?
Yeah, that's a good idea. And I think I will say this: I feel like a lot of companies have been really good about identifying this as a problem, and so they're notifying employees that that's the preferred policy to take right now. And in most places I know of, especially these big companies, have been very supportive of their employees, so far as encouraging that, letting them know they're not going to lose their job if they do that. They can self-monitor, self-report. And so instead of having someone come out to your house and measuring your temperature, you just keep measuring your temperature and go from there. For the people that have tested positive for the coronavirus so far, and there's a good recent article published in the New England Journal of Medicine this week, and they do a very nice, detailed description of the first positive coronavirus patient in America. And it's also a very good description about how mild it was. And this poor patient just sat in a hospital for 10 days, and finally they said he could go home. But a little more than a loose stool and a runny nose, the patient did fine. But what they're doing is they want to have 2 negative tests over 24 hours before they feel like someone's cleared it. And what we think right now is that people can still transmit the virus up to a month after they've had an infection. But that's still kind of up for discussion. But isolating yourself so far as, hey, don't go to nursing homes. Don't go see grandma or grandpa right now if you've got a fever and a cough and a runny nose. Protect them. That's who we're trying to protect. it definitely has a higher mortality in the older patients. And so if you're immunosuppressed and let's say you have lupus or rheumatoid arthritis and you're on immunosuppressive drugs, or if you are suffering from cancer and you're on chemotherapy, or if you have heart or lung disease, or if you're an elderly patient, all of us as a community, it's our responsibility to not bring ourselves close to you, to not risk exposing you to something that could ultimately hurt you and kill you. And I think that's probably the important message right now. Stay away from those people that we know are going to have a high risk of death. And that's why everyone's trying to be very, very careful about that. And when it comes to travel, it's the same thing. I think cruise ships right now, if I can throw out my opinion, I think they just need to be responsible and they just need to cancel most of the cruises right now. I mean, those are proving to be petri dishes on water. And I think that's one of the things that we want to protect lives. And I think the government is starting to actually look at some of these cruise lines for the same reasons. But we know that viruses like this spread very quickly in dormitories, military barracks, cruise ships, anywhere you have a bunch of people in a confined space. That's where viruses like this are very successful.
Well, good. I appreciate you sharing that because, having worked around the elderly in particular in the past, I unfortunately seen where a lot of folks in the nursing home in particular become infected because of maybe a sick staff member, that came to work sick and infected, quite a few people, or a family member that couldn't stay at home for a little bit longer and came to visit their loved one. And what they don't see is a couple weeks later, when that loved one goes to the hospital for a pneumonia or something that may be secondarily related to that infection. And I really feel very strongly about that.
Yeah, I think, it's our responsibility. But, an interesting thing is that a lot of parents, for example, do that, right? I mean, it's mutual respect to tell someone, hey, my 8-year-old had a fever yesterday, and I know that y'all have a birthday party tomorrow. I don't think we're going to be able to make it because I don't want to get anyone else sick. And that's common sense. And that's really what we're asking people to do is if you start having symptoms, don't panic. But then start thinking about, hey, we really don't need to go visit my parents this weekend, or I don't need to go see grandma in the nursing home. And my sister just had a newborn baby not my sister, but for example, and let's not go hug that infant right now. Let's be mindful of that. When people have new babies, that's what they usually do, right? You don't get to hold the baby unless you wash your hands. And if you're sick or have a cold, you don't get to come see the baby until you're better. And we already try to protect newborn infants because we know anything under 3 months with a fever, they're going to have a really bad time. And so I think it's the same methodology. It's the same common sense approach.
Yeah, well, thank you for that very much. I think that's going to be very helpful if folks will just take this information and use it use it wisely, and be good stewards of the people around you. I want to switch gears just a little bit, unless you have anything else to add on that note.
No, I think we kind of hit all the salient points there.
Yeah, cool. Well, kind of in the vein of what you do and in your work as an emergency physician, I'm certain you see a wide variety of illnesses and injuries. What I'd really like to ask you is, maybe what some of the more common illnesses and injuries are that you see, but even more importantly, what do you see that is most easily preventable and how?
Well, you just basically opened up a thesis on emergency medicine. We're the front lines of society. We're the boots on the ground, and we're the first people to see public health crises. We get to see the consequences of gun violence and alcoholism and drug abuse. And I live in it every day. I always tell people, I said, my job is at the intersection of humanity and happenstance. And it's just the things that I think are most preventable are usually the ones with the most dire consequences. For example, smoking. I can't tell you how many disease entities and deaths I see because of smoking. Smoking can cause COPD, and COPD is a chronic disease of your lungs, which means you can't breathe. I admitted 3 people just last night with COPD exacerbations and pneumonia, and they were very, very sick. And they smoked for 40 years. And we know that they wouldn't have COPD if they didn't smoke. So that's something that's preventable, and yet something that's deadly over time. But because it's a long-term consequence, we don't usually think about it in the now. And I think those are things to think about. Alcoholism. I had 3 GI bleeds this last week, and they all had significant liver disease from alcoholism. And I think it's something that, if you're an alcoholic and in society where alcohol is so readily available and socially it's so acceptable, it's hard for people to start thinking, hey, I have a problem. And people don't start realizing it until a physician starts asking them questions like, well, how much do you drink a day? It's like, oh, I just have a few mixed drinks. And I had a lady the other day who had a lot of significant issues and had to get admitted. But when we started talking about it, she had never taken the time to add up how many alcoholic beverages she had in the day. And she was drinking a fifth of vodka a day and a couple of glasses of wine on top of that. And I think things like that creep up on people. And I think it comes back to addictive behavior. And I think it comes back to mental health and mental illness. I think a lot of times, especially in our community, we have a large vet community. I think a lot of people try to self-medicate because there's a lot of pressure to not self-report. When I was a physician in the Army, we go through screening exams, but there's a lot of soldiers that were worried that if they were to open up about PTSD or depression or the issues that they're having from going down range, that it would be a career ender. I mean, there's a lot of people, especially in the kind of the tip of the spear community where the op tempo is very high, that if they show what they consider to be weakness, which it's not weakness at all, but if they were to show something like that, that they would be pulled off the teams and they would lose their career. And so, it's something that we see it with first responders. We see it with physicians. With the Texas Medical Board, for example, they're expecting you to self-disclose if you ever had depression or been treated for depression. And I've had friends where their medical license was actually held up at the TMB level simply because they admitted that they were on Zoloft and they had depression. And so now you've got this negative enforcement for people to self-disclose. And so the things that I see a lot in the ER, to get back to the original question, mental illness has a lot to do with it. I think mental health right now, our country does not have an answer for that. And I know that's a separate discussion, but we just don't have the facilities or the infrastructure to support people who are struggling with things like depression, anxiety, and PTSD. I've lost some very close family members that I've loved very much to suicide and to drug abuse. And I see it every day. And so, mental health, I think, is a big thing. I think the other thing when we look at a public health concern in emergency departments is trauma. And believe it or not, most trauma is avoidable, but it's making sure you're not drunk when you're on your ATV, like I had the other night, or making sure that if you're dealing with firearms, that you're very cautious and that the chamber is empty. And being very, very careful about the things that you put yourself out there for and in harm's way. There's just a lot of those things that it's always sad when you get a really, really bad trauma and it was avoidable. Some things aren't avoidable. I mean, I took care of the Fort Hood victims in 2009 with Hassan, and that was a very, very horrible day and something that nobody can really ever anticipate. So those things aren't always avoidable. But not wearing a seatbelt, for example, and then driving 90 miles an hour on the toll road in Texas and then rolling your vehicle, well, that was avoidable. So I think a lot of those things are things that we actually have control over. I think what induces a lot of anxiety and fear for people is when they feel like they could get hurt or die secondary to things out of their control. And yet there's so many things in society that we actually have control over. And the last thing that's really devastating that we see a lot in Texas because it gets really hot here is drowning. And we see a lot of drowning in active duty soldiers in the lakes that we have nearby because they don't know how to swim. And then we see a lot of kids that drown in wading pools and swimming pools, especially at apartment complexes. And it's just something, again, that is avoidable. You can do structures and fencing around those water structures or pools. And you should also get your kids out for swim lessons. And I think those things are horrific when you have to walk in and tell a mother that her 4-year-old is gone and it could have been avoidable.
Yeah, it's unfortunate. I've been there, and it is very, very, very unfortunate. And, to have seen the devastation and what it does to the survivors is just as devastating. And
yeah.
So I appreciate you for sharing that. Now, kind of going backwards a little bit, you started to talk about the tip of the spear, if you will. And as you know, I've had a little mini series and featured some PTSD experts in the field of the first response, police, fire, and EMS, and I know this is one of your second loves. This is what you do so graciously to serve our community. But having 30 years of experience in that industry and having suffered from some challenges of my own throughout my career, I'd like to go back to maybe some self-care for those in that industry that are struggling right now through the day in and day out kind of traumas and adversities that they see.
Yeah, I think I take this very personally. I've lost some family members and some close friends to mental illness, and more often than not, it's because they isolated themselves. They put themselves into a silo. I don't want to get into specifics, but we just lost a fire chief in Central Texas due to mental illness and suicide. And this man was a leader and was a much loved mentor to many people in the fire and EMS community. And it's just tragic. It's tragic because of the outpouring of support that he received after he was gone. And a lot of that support was there when he was alive. And I don't think he was able to see that. Nobody ever knows the specifics when someone finally makes that decision. And it's not fair to speculate about any of the details, but we know that the loss is tragic, and we know that the survivors that are left behind are also reeling from it with a lot of grief. And it's something that I think one thing I always tell people, and it's a message that I live by, is that you need to stay. You just need to stay. You need to, no matter what you think is going on or how bad it is or how dark it is or how much of a dead end you may feel that you've walked yourself into, you need to stay on earth. You need to stay. There are people that love you that you probably don't know about. There are people that see you every day when you pull up to the drive-thru at a coffee shop that enjoy seeing your face. There are people that you run into in church that are always happy to hug you and to hear from you. But when you put yourself in a corner, you're not able to see that. And there is a point in time where you don't have perspective anymore. And that's the most dangerous point in time for you. And so the first thing you got to do is stay. The second thing is to understand, especially for first responders and military, EMS, emergency personnel, you name it, understand that what you see is not normal. The things that we see and do in our professions are traumatizing, and that you are a normal human being. You are a normal human being with a normal psychological response to an abnormal human experience. And I think that's what you have to understand, that it is not normal to go pick a body up off of a railroad track. It is not normal to code or do a resuscitation on someone underneath a toilet in a nightclub at 3 a.m. It's not normal to have a mother run to you with a gray limp baby begging you to save that baby's life, and of course she can't. Those are not normal scenarios, and so you go home and now your brain is stuck with trying to process that information. And a lot of us, myself included, will go over and over and over these cases for days or weeks sometimes, and I have nightmares, and my wife always knows when I've had a bad night, because I'll get up, can't sleep, and then I'll go work on my book, or I'll go work out or something. But I also know that that's a normal response, because my brain is still trying to reconcile what it witnessed. And I need people to understand that that's normal. You're not weak. You are not broken. You are not less than adequate than any of your peers, because you're struggling with it. And the interesting thing is if you get in a good group and you start talking about it openly, you start realizing everybody feels the same way. I think the thing that's also important is to understand that you can't self-diagnose, and neither can your friends. And so if you're having thoughts or concerns, you need to go see a therapist. And there's a lot of avenues to help people. There's group therapy, there's individual therapy, there's equine therapy, there are service animals. There's lots of things that you can do and get help for. And I think that's the thing that you have to keep in mind. And I was kind of sneaky when I was in the Army. I had other questions I would ask that wasn't on the checklist for soldiers, the things that I needed as a physician to know that they were struggling. And then they would inadvertently or indirectly answer that. And that's when I knew to get them some help. And I will say, I can't speak for other military branches, but the Army was really good about providing peer groups and group therapy. The time that I was in the Army, what they were doing wrong and then identified it to change it was that a lot of times if someone was struggling with PTSD or anxiety or any of the wellness issues, they would pull them out of their unit. And then now they're even further isolated. And we started seeing suicide rates go up. And so what they found is that you should try to keep them with their unit, keep them with their peer group, and get them into therapy and watch them closely. And then I think the one thing that we all need to be protective over is people's career path. In the military, it's a lot about promotions, and people don't want to go and seek help and then not get promoted because that's the end of their career. So I think we have to protect those people as well. So far as self-help, I think one, don't self-diagnose. You definitely need to stay on this planet. People need you. You may not realize that yet just because you're in a fog. And then you need to do other things. If you're not that far yet, but you're just exhausted and you feel like you're getting burned out and not sleeping well, I mean, there are a lot of things you can do. But one, I always tell people, get outside. Staying inside and drinking alcohol and not going out into the world, those are not things that are very helpful. Alcohol is a depressant all by itself. But exercise, socializing, instinctively what you want to do is withdraw and kind of put yourself in a corner, and that's actually the worst thing you can do. Force yourself to go out with some people that you love and trust. Get outside, and if the things are getting more significant, then you definitely need to get therapy.
I thank you for that. And I want to kind of go back to where you talked about processing. And that's something that I was guilty of, and I see a lot in the first responder community is, for lack of a better term, how we tend to compartmentalize each and every one of these individual traumas and think we've moved past it. We put it away and kind of lock it away and think we're done with it, but it leaches out and exhibits itself in other ways later on, excessive alcohol use, anger management issues, depression and things like that. So I do want to reiterate the fact that you should really learn how to process these things early on.
Absolutely. And I think talking about that is a good start. It's the beginning. And you're right. I mean, and really we're kind of forced to compartmentalize it, right? Because, in the ER, for example, you'll code somebody and have a death, and then you got to go see 15 other people that they need your help also.
And smile.
Yeah. And smile and completely hide the fact that you're crying and you're struggling on the inside because you just lost a human being. But the person with their ankle sprain doesn't really care to hear that. They just want themselves to be taken care of. EMS last night, I'll just give you a personal story. I'm also the medical director over the EMS and fire department in this area. And a couple of young guys, they came into our facility probably half a dozen times yesterday. And that was just one medic unit. And so that was a lot of calls in just to one hospital, and they were also going to other hospitals, and they took care of some really, really sick, dying patients. And it was one of the things where as soon as they delivered excellent care to a patient and we received them, they were getting toned out for another one. And so you don't have time in the moment to process that, but you need to. You need to be able to process it. And so we're kind of forced to compartmentalize it, mostly out of a survival mode. But when the shift is over and you're exhausted and your brain is trying to wind down, it's a good time to go somewhere in a positive environment and maybe hang out with one of your peers or talk to a mentor. I'm a big fan of mentoring. I think none of us have walked this path in life without help and without teachers and without people wiser and more experienced than us showing us the way. And I think that, what we try to do, especially within our department and other entities, is establish that mentorship. And I think it's important, especially for first responders and military, to have a system set up where they can safely go and hang out with peers and discuss some of these things. And in the very beginning, that's what you need to do. You cannot bury this stuff. It will come back. It will always come back. Trust me, I've been doing this for a long time. And, it doesn't matter. It's like, oh, I've seen this a million times. It's not going to bother me. It's going to bother you. It's going to be so random. It's going to be the night before Easter, and you're sitting there having dinner with your family, and you're going to start crying, and you don't know why. And then you're going to think about that kid that you had to declare time of death on, and that's real. And so you need to process it and start moving through it. And then, I think it's a good idea to do maintenance mental therapy. I think it's good to see a counselor and to work through these things. Have someone who's a trained professional who can be objective about what you're experiencing and feeling to help you, because you really just can't manage this on your own. None of us can, ever. Even that one guy or gal that you think is just amazingly strong and is a pillar in the community, they can't do it on their own either. And that's why we're losing 20 plus vets a day to suicide, and that's why we're losing police officers every day. There's some horrible announcement that another police officer, seasoned officer, took their life, and it's because they just didn't have the support and the infrastructure they needed, and they just weren't willing to stay.
As we wind down on this, we talked a little bit about the virus. We talked a little bit about the folks in the public safety industry. But if you had to share one piece of advice with anyone that would improve their life in general, what would that be?
I think it's important to always remind everyone you're meant to be here. I think people that lose faith or lose hope often feel insignificant, but you're meant to be here. I mean, if you think about the miracle, just from the scientific aspect of it, of the impossibility or the improbability of you even becoming a fetus, and how complicated that is, and how many things can go wrong in pregnancy by itself, and then you're born, and then you're here, and despite all the viruses and all the bacteria and all the accidents and everything else that can go wrong, and you're here for a purpose, and you're meant to be here. And I think that's something that people need to understand and realize, that you don't have to be President of the United States. You don't have to be a celebrity. You don't have to come up with the most important invention in the universe. You need to be here because you're supposed to be here. And maybe your purpose is that one person that keeps visiting you at the coffee shop, helping them understand how special they are. Maybe it's doing a mission trip in a third world country where they don't even have clean water, and you're able to help them dig a well. I mean, there are things that we can all do that will not get recognition or ever make the evening news, but they are significant and they do matter. And I think those are things that people need to understand. You can make a positive impact with something as simple as a handshake and a smile. You never know what anyone else is going through. And it's something that you can share that positivity, that light with other people, and make a difference. And you need to understand that that's significant.
That is so awesome. Thank you for that. And I want to put a little icing on that. Your purpose is not to live angry, and it's not to live bitter, and it's not to live with guilt. And I think the more we can work to remove those things from our life, the closer to true happiness we are.
Yeah. No, I agree.
So, listen, one of the things that I know a little bit about you is that you are also an author.
Yes.
And you've got a couple books out. Would you tell us about that?
Yeah, absolutely. I think it's actually perfectly in line with what we've been discussing all day. I've always been a fantasy nerd. I was the kid in the library reading Lord of the Rings and the Black Cauldron and what have you. And I always found it fascinating, especially as I got older, to come back to those books that were on the surface very entertaining and realize that the authors actually had a lot of great life lessons kind of embedded throughout the details. C.S. Lewis with The Lion, the Witch, and the Wardrobe is a great example of that. And I went to college struggling with whether or not I wanted to be a writer. My mom was worried that I would end up being homeless and I wouldn't have a career. But like you and I kind of talked about before we started the podcast, I had a lot of life experiences in high school that kind of led to my path in medicine, but my love for writing never went away. And I found ways to write articles and do research on sepsis, and I wrote medical textbook chapters and stuff when I was in academia. It just didn't really scratch that itch for me. And I'd had this idea of how do you talk about mental illness in a way that is entertaining. And if you think about that for a minute, that's pretty challenging. Most people try to avoid mental illness because, I mean, it's a downer for some people, right? When they want to get entertained, they want to escape things. They don't want to necessarily think about things. So I was trying to figure that out. And I had a moment that I want to share with you that kind of highlights a lot of what we discussed today. It was towards the end of my shift one evening, and I got EMS was coming in, emergency traffic, GSW to the head, self-inflicted. And of course, they come in, lights and sirens, patient's intubated. It's a mess. I don't have to paint that picture for anybody in your audience, but we tried very, very hard to save this young man. And ultimately, he succumbed to his injuries. The hard part after that, besides, again, compartmentalizing what you just witnessed, is to go inform the family now what happened. And so I prepared myself like I always do, took a deep breath, went into the family room, and the room was just full of very concerned, crying, anxious family members. And there's this little boy in front of me in a cardigan sweater. And he was probably 5 or 6, somewhere around there. And I introduced myself, and before I even got to start, he ran up to me, and it's almost like he already knew what happened to his dad. And he grabbed my hand, and he was crying, and he says, "My daddy going to go to hell." This was a very devout Catholic family, and kind of like what you and I talked about early on, you know, a lot of denominations and different religions in general have a concept of the afterlife and right and wrong and damnation and paradise. And I started crying. It shook me to the core that this young child was already moving past losing his father, but he was worried about the eternal destination of his dad. And I just looked at him, and I did the best I could in that moment. And I looked at him and I said, "No, son, I don't think God punishes those that suffer." And I really believe that. And I drove home that night with that story. And I thought, how unfair is it for this kid to think that this man that he looked up to and loved was struggling and suffering from depression and mental illness. And his fear is that this person that meant so much to him is going to be punished forever. And I thought that was just a horrible, horrible thing to take away from something like that. And so that was kind of the impetus for me. That was the inspiration. And so in this book, it's called Hippocrates and the Hobgoblin, the Child of Mutandur. And it's the first of what I think will probably be a 4-book anthology. I've just finished the second book, and I've done about 6 of my own edits, and now I've sent it off to Oxford for formal edits with Jericho writers. And it's going to go into a 3rd and a 4th book. But what it details is Hippocrates was what we kind of call the grandfather of medicine. And so the main character, Creed, first arrived to the afterlife as Hippocrates. That's how they know him there in the world of Mutandur. And then he became a part of this specific unit called a Luxatio, and he was returned back to Earth in so many different lives over time, trying to help humanity. And in the struggle of this storyline, there's a populace of people, souls that return to this world, and they're called the Vegas, and they're people that suffered from mental illness on Earth. And when they arrive, they're often confused, and then they receive some level of punishment and become these creatures that are very grotesque and scary, but on the inside they're suffering. And Creed, who's the protagonist in the story, is very upset with this and the balance of immortality, and he tries to find a way to provide some means of salvation for these Vegas. And it was a way for me to kind of challenge this concept that people who struggle with mental illness and maybe succumb to their disease, they don't deserve eternal damnation. And what that means to me is that people don't understand the true process of mental illness. I mean, if someone died from diabetes or someone died from a myocardial infarction, you don't send them off to hell, And yes, we can talk about life choices and other things, but we know that depression and different variants of mental illness like bipolar, schizophrenia, there's a true pathophysiological process to it. It is a series of neurotransmitters and how the brain is able to bind those neurotransmitters and respond and create that person's sense of reality. And when that is skewed, the brain is the only organ of the body that's responsible for taking care of itself. And when the brain is sick, how can it possibly take care of itself? And I think that's something to keep in mind. And so in the story and the reviews and everything, it seems to have really touched a lot of people. When you create something that means a lot to you, you don't know how it's going to be received. You don't know what the world's going to think of it. And it's been received really well. And I've been really happy with the process. I've had people message me and, on the surface, for people that just want to read a good book, it's very entertaining. It's a lot like Lord of the Rings, and it's an epic fantasy with creatures that I've created and worlds that I've created and characters that are pretty deep. And then for people, I think, that recognize some of the cues of it, they start to understand that there's a deeper message to the book. And I have a hero that has autism. The main character, Creed, has PTSD, and it's manifested through his memories of all the prior lives that he's lived, which very much reminds me of a lot of the people I work with in emergency medicine. I in a way, you can think of almost every ER shift as a separate life. There's a lot of things that you learn and recover from, but then, stays with you for years afterwards. And the same thing for EMS and police officers and whatnot. And so the band of people that come back life after life are called luxatio, which is Latin for dislocation. And so they're like dislocated fragments of light that keep going back to Earth, trying to bring the light to humanity. And so when you think of people like Aristotle or Gandhi or Martin Luther King, I would think of them as luxatio. What is it about a person that stands above all others, that inspire the rest of us, that give us hope, that give us a path of light? Why are they like that? And for me, I consider that to be very powerful. So I took a lot of those themes and put it into this book. And I'm excited about the second book. I've got a friend right now who's downrange. He's the only person in the world who's read the second book. He's a beta reader for me. And he texted me the other night. He's about 8 hours ahead of me. And he goes, "You've got to be kidding me." Is how and I said, "Don't worry." I said, the third and the fourth book, there's a purpose to all this. But I think at the end, what I want people to understand, I want them to have a good time when they read the book. I want it to be entertaining. And at the same time, I also want them to understand and believe. And I'm a big fan of redemption. I'm a big fan of second chances. And all these characters are able to go through that on their own.
That's super cool. How do we get a hold of the first book?
So it's on iTunes. It's on, you can get it at Barnes & Noble. You can get it on Amazon. And I just published an audiobook. So for all of you busy people out there, I've got a lot of doctor friends right now that have listened to the audiobook and have been blown away. A lot of times for them commuting, it's easier just to listen to the book instead of sit down and read it. So it's available on multiple platforms. You can start by just going to Amazon and you can see the Kindle version, the paperback version, and the audiobook version. So I'm going to release the audiobook a few months after the printed version, but this fall when I publish the second one, we'll probably do both at the same time.
I can't wait to read it. Thank you so much for sharing that. And I want to thank you so much, Dr. Colvin, for coming on the show today. It's been awesome, and I hope you'll be a guest in the near future.
I look forward to it, man. I appreciate your time.
All right, thank you. I want to thank Dr. Colvin again for coming on the show, and I want to thank you for tuning in to another episode of Mind Hostage. Please tune in for our other episodes, and if you'd like to give us feedback, you can email us at themindhostage@gmail.com. You can also look us up on www.mindhostage.com.
Loved what you've heard on this week's episode? Well, the answer is simple. It would mean the world to us if you could head over to iTunes and leave us a 5-star review and feedback. spreading the word really is the best way to grow our podcast and achieve even greater things. Thank you.